The Knee Gurus, the latest research and advice from industry experts for best practice management on knee injuries and pain. Here's your host, Bevan Colless.
Hey, welcome back to another episode of The Knee Gurus. I'm your host, Bevan Colless, and we're very excited to have with us today Professor Ian Harris, who is an orthopaedic surgeon based in Sydney, in a town called Liverpool, where he conducts his clinical practice. And he's also conducting research at the University of Sydney and University of New South Wales, and currently conducting some research into surgery versus non-surgery for rotator cuff tears, and has had a long history of conducting research. And he's also the author of two excellent books, one called Surgery, the Ultimate Placebo, and another one called Hippocrasy, which you can see there, which I've read. And his special interest covers surgical outcomes and comparing surgical outcomes with non-surgical outcomes, and researching patient satisfaction, clinical trials in orthopedics, and the effective compensation on outcome after injury. So he's also a member of the Australian Academy of Health and Medical Sciences, Royal Australasian College of Surgeons, Australian Orthopaedic Association, the OA Foundation, the American Academy of Orthopaedic Surgeons, Orthopaedic Trauma Association, Australasian Orthopaedic Trauma Society, Australian Medical Association, and Asia Pacific Orthopaedic Society. So we're very privileged to have such an esteemed guest with us today, and we're going to dive into surgery and how it affects particularly the knee, and see what Ian Harris can add to the discussion that we're having here. So Ian, thanks very much for coming on today.
My pleasure.
How did you end up writing these books? Coming from being it's a bit of an unusual turn for an orthopaedic surgeon to sort of pivot to this type of work.
Yeah, I think there was I saw a need for the message that I was carrying in the books, and the message of a lot of my talks, to reach a wider audience, and not just a medical audience. So I think most people who probably read the books have a health background, but not all of them do. And it's partly to educate the public in general was the reason that was behind writing those books. Because I think the public need to be educated. It's one thing saying that practitioners need to be educated, and they do. But I think the public needs to be more science aware as well. And there's too much. It was also done to sort of counter the prevailing myth around a lot of medicine, where everything you read in the papers was, miracle cure for this. Everything's wonderful. Isn't medicine great? And that's all you read about. And it's really, you never hear the downside of what we do, all the harms we cause. It's a huge problem, but it's never reported, and it's really underexposed in the community. So I really wanted to balance that perception of medicine a little bit.
And do you feel that it's been effective? Have you had good feedback from, I guess, potential patients, the general public as well as?
I've had nothing but positive feedback, and a lot of feedback, and emails and messages and things from people, and a lot of consumers, a lot of patients. And I think in general there's a greater awareness now of the limitations of medicine, of some of the biases that doctors have, and I think there's much more awareness, and whether that's due to my books or whether that's due to just people being more aware, because there's lots of other people who are saying the same kind of message that I'm saying as well. And you've only got to look at recent high-profile cases where the so-called maverick surgeon or surgeon heroes are being brought down a little bit, and people are questioning what they're doing. Whereas previously it was, surgeons could do no wrong. Everything they did was good, and they were all heroes. And now it's kind of like, well, some of them are doing things that maybe they shouldn't be doing.
Yeah, yeah. And one of the things that you delve into quite in depth in the books is the scientific model and evidence-based practice, and comparing the requirements for surgery with, say, other interventions such as medication. Do you think you could sort of compare and contrast those two differences?
A lot of nearly all of my research is on surgery because I'm a surgeon. But also because surgery was seen as kind of exempt from the scientific requirements that were placed on other things. So if you want to get a drug picked up by the PBS, you want to get the government and the insurers to fund it, you've got to put forward pretty rigorous evidence that it works. You need a placebo trial or a comparative trial, a randomized trial, or several randomized trials in order to be able to show that it works and to get it funded. But with surgery, you never needed that, and the general consensus was that operations worked. But I think that the same scientific standard should be applied to surgery, and it can be, and it is. And often we find that when we do apply a high scientific standard to testing our surgical procedures, they fail. And to me, that means that we should be applying it even more. And yet many surgeons feel that surgery is exempt and they know when operations work and when they don't. But part of my job is to point out to them that our perception is often disconnected from reality. And we often think things work because we see people get better, but that doesn't mean that they got better because of what we did. And they may have improved even if we had not touched them. And it's that kind of thing I think is strongly needed in surgery. And unfortunately, there's a reversal in the burden of proof. Surgeons go out there and do operations that they think work. And to them, the burden of proof is for someone else to come along and show that it doesn't work before they stop doing it. And that, to me, is upside down. I mean, the burden of proof is on the person the proponent of the operation. They need to prove that it works before it becomes common practice. But what happens is operations become common practice. Some years later, somebody shows that it doesn't work. We stop doing it. We make up another operation. Years later, someone shows that one doesn't work. And there's so many operations that are not done anymore that used to be commonplace. We're still not catching on that that's not the way of doing things.
And so I guess what's difficult with surgery is, as opposed to medication, is implementing a control group to mitigate the placebo effect. But I understand you're a proponent of using sham surgery as a control group. Could you talk a little bit about that?
Yeah, not always, but I'm involved in a few of those studies. But it's important when you're doing an experiment to find out if something works or not, that you do the least biased experiment you can. And often that involves blinding the patients. So if the patients know that they had the operation and the patients who didn't have surgery know that they didn't have surgery, you tend to get biased answers from them. And so if you were trying to look at the effectiveness, you mentioned rotator cuff repair, which is what we're doing at the moment. And if you interview a patient who had a rotator cuff repair and you said, how's the shoulder feeling? They're more likely to say, well, I guess it's feeling better. I mean, I had the operation, so yeah, I guess it's a bit better. And if you interview the same patient with the same amount of pain, and you say, and they didn't have surgery, and you ask them how their shoulder is, they'll probably say, well, it's no better. I mean, I didn't have the operation. Why would it be better? Whereas if the patient's blinded, they've had surgery, but they don't know whether they had the rotator cuff repaired or not, you get a completely objective answer from them. And so just like you blind patients with a placebo pill, you can blind patients with placebo surgery.
And how's sham surgery sort of been received by ethics committees?
Very positively. So all of the ones we've done have gone straight through ethics, because the ethics of it is partly based on the ability of the scientific merit. The scientific merit is very high in such a study. The ability to find an answer, a true answer, is very high. And these studies satisfy all the requirements of every other study that we do. Patients are fully informed, they understand what the risks are, they can withdraw at any time, and then you've just got to say that the benefits outweigh the risks. And that's easy to say, because on the surface you might just think, oh, you're operating on people and half of them won't get the operation. That's terrible. You're exposing them to harm or potential harm without any potential benefit. But that's what we're doing now. We're doing operations which are more harmful than a placebo operation, that involve more, implants and cutting, and are more invasive, and we don't know if they work. So we're exposing people to more harm now without any evidence that what we do works. Surely, instead, the example I give is with spine fusion surgery, where we're doing more than 1 million spine fusions are done every year. Most of them are done for back pain. It probably doesn't work, and we certainly don't have any evidence that it does. Surely taking 100 patients and randomizing half of them to having a spine fusion and half of them not having it, and finding out if it works or not, is better than continuing to just operate on 1 million patients a year with incredible costs and harms for something that we don't know works. So the ethics of it is a very easy sell. It's one of these quick things where people say, oh, surgical placebo trials, that's unethical. And you think, oh, yeah, I guess so. But when you think about it for a second, you go, no, what we're doing now is unethical. A scientific trial to find out whether what we're doing now works or not is not only ethical, it's demanded. It's unethical not to do such a trial. To continue practice without a trial is unethical.
It just requires a change in flipping on its head your normal thinking process, I guess, which is...
Yeah, there's no ethical requirement on a surgeon to report on the effectiveness of a new operation. And there's no ethical barrier for them to start operating. So if I thought up a new way of doing hip replacement, if I operated through the back of the hip instead of the front of the hip, something like that, or the side of the hip, I can do that. There's no ethical requirement on me to report on it or to prevent me from doing it. So I can do a new procedure without any ethical oversight. But once I've done that procedure, if I decide I wanted to do a study to find out if it works or not, I'm not allowed to, unless I get ethical approval. So it's completely the wrong way around.
And how about getting consent from a patient before you do a surgery, if a surgeon's going to do a procedure that might be new or the first time they've done it, or a little bit of an experimental procedure? Are they required to outline that to the patient before the surgery?
No.
Not at all, huh?
They're meant to outline the relative risks and benefits of the procedure, regardless of whether it's new or old. But no, there's no regulation around new procedures. There's regulation around new medication. There's no regulation around new surgical procedures.
Yeah. And how have you found getting consent or volunteers for a randomised control trial where a patient might be going into the surgery and then you tell them, well, look, we're doing a randomised control trial and there's a 50% chance that we won't actually be doing a surgical procedure on them?
Yeah, for the current study we're doing, we're getting around 2/3 of the patients who are approached agree to the study.
Pretty good.
The main reason why people agree to a study like that is actually altruism. They like the idea of being an important part of a study that will help people in the future, not necessarily themselves. And so that's a big driver for people. And we're doing a sham surgery study in the spine. And I remember one of our elderly patients who joined that study, who said they felt this was one of the most important things they'd ever done, to be part of an experiment that would answer such an important question and help other people in the future. Really gave their life a lot of meaning. This is something that people see as a very positive thing in their life that they can contribute to. So, but not everybody does, sure. But that's the way it is. It's voluntary. It's people get invited to participate, and they get to choose whether they join or not. I'm just outlining that people. The attitude that people have towards potential patients is that they're all selfish, and why would they choose to have a 50% chance of having an operation when they could have a 100% chance of having it? And the answer to that is, well, once you explain to them that we don't know if the operation even works, and it may actually be harmful, they have a different view of it. But also, we tend to underplay the fact that people aren't selfish as much as we think, and they often will do things that will benefit others, not themselves.
Yeah, I was just listening to a podcast yesterday, The Revisionist History by Malcolm Gladwell, where he interviewed some people who were volunteers for a starvation study done in the Second World War, who were conscientious objectors and didn't want to participate in the war, but they felt they were helping the cause and helping the country by participating in this study. And some of them had terrible health problems, lifelong health problems because of it, but they asked them 20, 30 years later if they would do it again, and every single one of them said, most certainly I would. It was one of the most important things I've done in my life, and I'm proud of what we did, and it's exactly to that point.
Yeah.
And so you were talking a little bit before as well about the surgical scrap heap, and I guess that's the thing, particularly with orthopaedic surgery. So many of the operations that are done, it's a bit of a grey area whether we should operate or not. And as a physiotherapist, we're often having these conversations, as are the surgeons. Obviously, if you've got a displaced fracture, then it's a no-brainer. But for so many other surgeries, it could kind of go either way. You do outline them in the book, but what are some of the historical orthopaedic surgeries that have ended up on the scrap heap, and are there any interventions today that you can foresee in the future? Well, it's a bit forecasting and speculative, but maybe end up on the scrap heap in the future.
There's so many. It's hard to sort of. I don't have a list in front of me, but I do remember a talk by a very senior orthopod from the Netherlands, and it was he used to travel around the world giving this talk, and it was kind of like a humorous talk. He'd give it at the end of a course, and but it really wasn't funny when you looked at the topic, because he went through all of his publications and he published on all these new techniques, operations and procedures and ways of doing operations. And he went and described each of the papers he published and how they described this new technique and how they thought they were wonderful. And he went on to show that by the time each study was published, or by the time it had been sort of listened to and taken up, he'd stopped doing that procedure because he felt that it didn't work anymore. And so he was making up procedures, year after year, and then discarding them a year or two later because he found out they didn't work. There's so many. One I like to talk about is, because I have a sort of personal involvement in it, is tennis elbow. And tennis elbow is a very common condition. A lot of people in middle age get lateral epicondylitis or tennis elbow, or whatever you want to call it. It's a really common condition. And it's interesting because it's one of these self-limiting conditions. If you follow patients with tennis elbow, I don't know what that, something like 97 or 98% of them have resolved after a year or 18 months or something like that. So that it tends to just get better. And that's why there's so many treatments for it. And I'm sure physios have got their treatments for it. Chiropractors will have their treatment for it. Surgeons have got their treatment for it. Rheumatologists have their treatment for it. But the thing is, it just gets better anyway. And I'm not sure that any of the treatments we have work. I was a patient with tennis elbow, and I volunteered for a placebo study of injection where I was injected with either placebo, steroid, or stem cells. And I think that paper still hasn't been published yet. But I do remember an interaction I had at a lecture or a debate I was involved in on stage at an orthopaedic meeting. And I was talking actually about shoulder surgery at the time and subacromial decompression, because that's something that's been shown to be no different to placebo or non-operative treatment. And I said, I think, and my argument about shoulder decompression was that it's going to go the way of tennis elbow surgery, whereas when I was doing my training, it was a common operation. But these days, it's not often treated surgically because surgery is not effective. And there's even been a placebo study to show that it was no different to placebo surgery. And I used that line about tennis elbow as a bit of a throwaway line to support my argument about shoulder surgery, thinking that it was sort of widely accepted. And an older surgeon got up from the audience and he was very angry. And he said, what are you talking about? He says, the reason why tennis elbow surgery doesn't work is because they're all doing it wrong. I do it this way, where I release, this muscle and I cut here, and I still do that operation, and it works every time. And to me, this is just a classic example of what's wrong with surgery. This guy made up his own operation and felt that it was had a 100% success rate at 12 months, when 100% of his patients would have gotten better at 12 months if he hadn't touched them, of course. And it just shows you, what's wrong with surgery. I challenged him at the time. I tried to make him understand the difference, but it's very difficult.
Yeah, I guess it's pretty understandable that you might have received a bit of pushback from within your industry. Obviously surgeons they're the top of the hierarchical medical model, and obviously all very bright, well-educated people, and aside from the financial aspects of operating in the private system, there's also, I'm sure, you all work so hard to become surgeons and study for years and practice for years that I imagine there's a feeling that you just like to do surgery because it's I guess in many ways the end point of all that hard work over the years. So I could imagine to have someone sort of push back and say, well, maybe you shouldn't be doing surgeries, may not be so well received. Have you received a lot of pushback from other surgeons?
Never to my face, but I think that there is a lot of negative feeling out there, but I very rarely get it put to me personally, but have occasionally. I think it's easier for me to push this message because I'm a surgeon, and I've seen many cases where non-surgeons, whether it be a rheumatologist, physio, or anyone else, lecture that surgery may not be effective, or this operation doesn't work, and it's just completely dismissed and not even taken seriously by surgeons. But when a surgeon tells them that surgery doesn't work, I think it's more effective. So I think that's been helpful. for me to be a surgeon, and it's a little bit harder for them to dismiss it, because often they say, "Oh, you don't understand. We see these patients, we do this operation. We know that it works." And when I say to them, "I see these patients and I do this operation, and I no longer do it anymore because I know that it doesn't work," it's harder to argue with. So I think that's helped me. There's been there's still a lot of surgeons who are doing operations that probably don't work, but they don't understand the science. So when you say, "Oh, they're highly trained and highly paid, and they're at the top of the ladder," I think they probably are, but they shouldn't be. What puts surgeons up there? Surgeons earn more than anybody else, and then I think people just think, "Oh, well, they must be like the most highly trained and the smartest and the most right," but that's not true. They just get paid more. That doesn't equate to anything else. And often they're not. And this goes for any health practitioner. Often they do not get trained in the scientific method. I was never trained in the scientific method, and certainly never trained in the scientific method as part of my surgical training. And I did a lot of surgical training, and I did fellowships, and worked with a lot of people in different countries, and I never got trained about the scientific method. And basically it's an apprenticeship, and I got to see lots of operations, and I got to see lots of surgeons who did particular operations, and I just figured that was the operation you did. And so a lot of surgeons end up just doing what they got taught, and do not get taught to question it or look at the science behind it or understand their own biases, unfortunately.
So, on that note, I mean, as a physiotherapist, there's certainly a lot of treatments that we do that don't have great evidence behind them, and some that, we may even know don't really work. For instance, if someone, but we might get some pressure or requests from patients who come in and say, "Oh, well, look, I just want some ultrasound for my lower back pain, therapeutic ultrasound," which is pretty much been shown to be a waste of time. But as a physiotherapist, you've got a paying customer, and you feel like you want to provide the crowd pleasing treatment, as we say. So we'll say, "Okay, we'll do the ultrasound, and maybe we'll also do some manual therapy and exercises and other treatments that have got a little bit more evidence behind it, but we'll probably still do the ultrasound." And that way the patient's not walking out saying, "Geez, I came all the way here for that magic ultrasound and didn't even get it." And I imagine there's something similar with consultations between surgeons and patients, where patients coming in, "Look, I just want this operation because my friends have had it and I had it on my other limb." And I guess that's a difficult time for a surgeon, a difficult discussion for a surgeon to have. How do you sort of manage those moments?
The stakes are higher. And I think that most surgeons who recommend surgery are doing it because they believe it works, which is actually a bigger problem. Ethically, it's less of a problem because the surgeon, believes it works, but it means that there's a bigger problem that surgeons don't understand the science behind it, and surgeons are very dismissive of randomized controlled trials that were done in another country, because it's so easy for them to just say, "Oh, well, I do it better. I do it differently," to them. And they don't understand that what I say to them, "Okay, well, if you think, like I said to the surgeon about his operation on tennis elbow, I said, if you think that you have the cure for tennis elbow and you're the only one in the world, or you owe it to everyone in the world to do a study to find out if that works or not, whether what you think is true. You need to do a trial comparing it to not doing the operation to prove that your operation works." It's too easy to dismiss any study. I mean, there's no perfect study, and when any study comes out, you can say, "Oh, I don't like the way they did this, or they didn't do that, and therefore I will continue doing something that's completely unproven." It's unfortunately, it's just too easy to do that, unless we change the rules where we say, "No, you can't do things that are unproven unless you're doing them as part of a clinical trial to find out if they work or not."
Yep, yep. And so if we can just get a little bit more specific on knee surgery, because a lot of our listeners are listening to this who may have had knee injuries or are trying to weigh up whether to have surgery for a particular condition, and probably don't get a chance to hear from someone like yourself. Say someone's got osteoarthritis, and we know that the evidence for arthroscopic surgery for osteoarthritis is not great, and there's a Finnish surgeon whose name escapes me now, who's been quite vocal in trying to encourage surgeons to stop doing that. But even surgeries such as microfracture and the Oates cartilage transplant procedures, would you have any advice for people who are thinking about those types of procedures?
Yeah, there's very little evidence that surgery can change the course of, or really in any lasting way influence the symptoms of osteoarthritis, beyond replacement, of course. I'm talking about the kind of procedures you're talking about. We can even talk about knee replacement as well in the future, but the arthroscopic surgery and even the sort of drilling and things like that, it's a waste of time for osteoarthritis. And if anything, there's probably some evidence that surgery to remove, because the only thing we do when we do surgery is we remove things. We shave them down, we drill them out, we cut them out, probably adds to the degenerative process by removing what little there is there in the way of cartilage or meniscus. So surgery for osteoarthritis to try and reverse it, beyond doing a joint replacement or an osteotomy is not worthwhile. And there's certainly a lot of other ways we can treat osteoarthritis, either by a simple medication, exercise, or weight loss. Weight loss is turning out to be a very effective way of treating knee osteoarthritis, probably more than we thought. Most of the patients with knee osteoarthritis are obese, or most of the patients who have knee replacement are obese, and losing weight can even reduce your symptoms to the point where you no longer need a knee replacement. And so there's some very interesting evidence coming out on that, and more studies being done on looking at how we can treat people better with non-operative measures rather than operative measures for knee osteoarthritis. And that means avoiding knee replacement as well.
Would you say that losing weight has extra benefits aside from just reducing the manual load on the joint? There's something to do with inflammation and.
So when I see patients who are obese and have neo, I first explain to them the benefits of weight loss on their knee, and I say, even if it doesn't help your knee that much, the health benefits are absolutely huge. Their diabetes can be reduced or even reversed, and all of the complications from diabetes and the heart disease, kidney disease, eye disease, peripheral neuropathy, all of these things that are secondary to obesity and the things that obesity leads to, can be reduced with weight loss. It's an enormous health benefit, but it's often not seriously considered by either the patient or the surgeon, and the discussion too much is a brief one, like, well, you could lose weight. Oh, it's too hard to lose weight because my knee's sore. Well, we'll just do the replacement then. That's kind of it. Instead of educating them, so instead of saying, well, you can lose weight because you can diet. Having knee pain won't stop you from dieting. And dieting may actually help your knee pain. So then you can also exercise. And as your weight goes off, you can do more and more exercise, lose more and more weight, continue the diet. Your diabetes will be under better control, etc., etc. It's possible. People do it. It shouldn't be just dismissed out of hand. And unfortunately, I don't. I'm blaming the surgeons a bit, but also I think in general there's this attitude that, oh, it's too hard to lose weight, or if I do lose it, it'll all come back again, and all diets fail. Not necessarily. It depends a bit on the patient. We all know lots of people who, lost a lot of weight and kept it off. I've got a friend who's an orthopaedic surgeon. Several friends who are orthopaedic surgeons who lost a lot of weight and took up, cycling or running, and watched their diet, and they've kept their weight off for decades.
I guess some patients think, oh, well, I've been told to lose weight by people for years and years. Why do I have to go and see a surgeon to be told the same thing that everybody else is telling me? So the surgeon probably feels a bit similar, that you've probably been told this. But I think if it's coming from a surgeon who's about to perform quite a serious operation on them, it carries a little bit more weight, you'd think.
Yeah, also that we normally tell them that the complications of the procedure are much lower if they lose weight as well before the surgery.
And just getting on to joint replacements. Now, we know hip replacements tend to have the highest patient satisfaction in post-operative surveys, and most patients who have hip replacements will say, oh, my biggest regret is not having it done sooner, and it tends to be not quite as effective for the knee. Would you say the satisfaction rates don't seem to be as high? But you sort of alluded before that maybe knee replacements are a little bit being overdone or handed out or done a little bit too quickly.
Yeah, I think there's a lot of evidence for what you said. So first of all, to cover hip replacements. So hip replacements haven't been subjected to a randomized trial comparing them to non-operative treatment. We actually tried to get one of those trials up and running, but it's very difficult. Even surgeons who are sympathetic to doing such trials found it difficult because the benefits from a hip replacement for somebody with severe osteoarthritis are so large and immediate that it's difficult to deny that treatment. And when you do look at patient-reported outcomes after hip replacement, they are very high. So you're looking in the high 90s of patients who rate their hip as being very much better. And normally it's fairly immediate. There's not a lot of post-op pain. Patients can walk very quickly after a hip replacement and immediately notice a big difference in their mobility. So it's a highly successful operation. And the numbers for knee replacement are not nearly as good. So the patients who say that they're better afterwards or who have no pain afterwards is not nearly as high as hip replacement, and also not as high as they expect. So there's definitely problems with knee replacements where we've shown that nearly all patients, a very high proportion of patients preoperatively expect to have no pain and no restriction in their activity. So they're expecting to have a normal knee after a knee replacement, and we know that that's not the case. Many of them still have pain now. Maybe a lot less pain than they had before, but many of them still have pain. They still have restricted mobility. Often, difficulty bending the knee is a very common problem, and these sorts of problems are much more common after knee replacement than after hip replacement. Now, that's not to say that on average people benefit. But there are ways of picking which ones benefit best and which ones don't. And there's certainly evidence now, and we've produced some of this evidence, showing that people whose osteoarthritis isn't that bad beforehand do not improve very much. And so people with very severe osteoarthritis and severely incapacitated, well, they're the ones that will improve quite a lot after a knee replacement. But somebody with an X-ray that doesn't look too bad, who has a knee replacement, often won't be very happy with the result, and often because there's other things going on. There's other reasons for them to complain of knee pain other than the osteoarthritis. And Australia does have a fairly high rate of knee replacement compared to other countries, highest in the world, but certainly above average. And I think it needs to be looked at. I think there's a lot that there is this feeling that there's nothing you can do. Once somebody's got osteoarthritis, you either replace the knee or you just tell them to put up with it, is an attitude that's not justified anymore. There are things we can do non-operatively, and we can even not only delay but avoid surgery. And even if it's a 10 or 20% of patients, that's a lot when you're doing 60,000 knee replacements a year, which is what we're doing in Australia.
So you're saying that the radiographic findings should almost trump the subjective symptoms if you're deciding to operate?
They certainly should be considered, and I think you see someone with knee pain, and you think, okay, well, there's nothing else I can offer you. I can only offer you a knee replacement, take it or leave it. You need to look at the X-rays, and if you've got an X-ray that concurs and shows terrible knee osteoarthritis, that's one thing. But if you've got a patient with a knee X-ray that doesn't look very bad, but they're complaining of severe pain, red flags should come up, and we should be thinking, okay, maybe there's something else. Maybe this patient has a chronic pain condition, or there's other things going on in their life that are causing them to maybe perceive the pain as being greater than the physical source of the pain. And we see that a lot in back pain and neck pain and other things as well. And, maybe we're better off not operating some of those patients.
Yeah. And what about people that might have been diagnosed with meniscus tears or even a bucket handle tear in the meniscus that they're considering a meniscus repair on or clean up? What's the evidence for surgery on those procedures like? And
I'll probably divide them into two groups. So people who have degenerative changes. So particularly if it's a degenerative tear in the meniscus, which is what most of them are. So these are patients who are over middle age. These are patients who are 40s, 50s, 60s, 70s. And many people in their 60s and 70s will have a degenerative meniscus tear. And it's secondary to the degenerative changes in their knee. Repairing that, I don't think there's any good evidence that repairing that helps. There's very good evidence that taking it out doesn't help. And I don't think there's a surgical solution for that. I think it's a different story at the other end of the spectrum where you've got a younger patient with a rather pristine knee. In other words, no degenerative changes. And they've got an acute, not a, long-standing gradual degenerative thing, but they've got an acute, maybe a sporting injury with a large meniscus tear. I think we need more evidence in this area, but I think it's a different kettle of fish than the degenerative meniscus tear in an older person. And if it was my knee, as a younger person, or my kid's knee or something like that, I probably wouldn't have a problem with them trying to repair an acute tear, knowing that they could always take it out if it falls apart or whatever.
Yep. I guess the latest one that's become a hot topic is the ACL reconstructive surgery. I'm not sure if you've been following the cross-bracing protocol and the Canoon study out of Sweden. It's kind of questioning the effectiveness of that surgery. Would you have any advice for people that might have ruptured their ACL and be considering their options?
Yeah, I think it's a good one because it's certainly an operation that can work. This isn't an operation that's a placebo or whatever. It's an operation that can help people. But like many of the operations I talk about and all the operations I list in the book, it's just another example of an operation where the benefits are overestimated and the harms are underestimated. And people think, and a lot of surgeons think that, if I reconstruct your ACL, you'll be back on the field, you'll be, like you were before. But when you look at the actual evidence, a lot of people do not return to the level of sport that they had before. A lot of them re-rupture when they do. and there's still some residual instability in some patients. It's not the perfect operation that we think it is. And, even though it works in most of the patients, and many patients do return to sport, sometimes they're still at risk of getting degenerative changes. They're still at risk of re-rupture, and they can still have residual stability. When you look at the ACL, it's a complex ligament, and what we do surgically is pretty basic. We just drill a tunnel through the middle of that and replace it with something else that doesn't look a whole lot like the original. So you can understand that it's not going to be a perfect restoration of the previous anatomy and function. But look, it's an operation that has a place. Again, Australia has this reputation of overdoing it. And if you compare it to other countries where some patients are considered for non-operative treatment, in Australia, it's very, if you have an ACL tear and you go and see the average orthopaedic surgeon, they will recommend a reconstruction. I don't. I certainly try all my patients with non-operative treatment first. The landscape has changed a little bit because there's some interest now in non-operative treatment as a way of getting the ACL to actually repair. The thinking prior to that was that once your ACL is torn, it's torn. It will never repair on its own. And it needs to be replaced. So what we call ACL reconstructions are basically taking out the torn ACL and replacing it with some other tissue. And whether that be a ligament from somewhere else in your own body or someone else's body or an artificial, whatever, you're not repairing the original one, you're replacing it. But there's some evidence now, and we certainly need a lot better evidence, that with certain bracing protocols treated after acute tears, not after chronic tears, but after an acute tear, you can get it to heal in a certain proportion of cases, which then can avoid the need for surgery, and you would have your own ACL back again, not a replacement. And so there's several people around Australia and internationally that are looking at doing randomized trials now, comparing this bracing technique for recent tears, comparing it to either non-operative treatment or comparing it to a reconstruction.
So what's your sort of advice that you're giving patients in your rooms who are presenting with acute ACLs currently?
At the moment, I'm not doing that bracing protocol, but I'm certainly interested in it, and I'm certainly interested in recruiting patients for these upcoming trials, which I'm also involved in. But my advice usually is non-operative treatment. It depends a little bit on the patient, and we know from a lot of evidence over many years that if you've got a 40-year-old office worker who plays weekend football, I'd certainly advise non-operative treatment to start with and sort of see how the knee goes. And often they're happy to downgrade their sporting activities, and they live a long and happy life without an ACL. But then the other end of the spectrum is the 18-year-old footballer who wants to do it for a very long time, and we know that they're much more likely to end up needing a reconstruction, that they won't tolerate the non-operative treatment. But they're the kind of patients that we need to maybe recruit for these new studies as well, to see whether we can avoid reconstruction in a percentage of them. Because at the moment, the proportion of 18-year-olds with acute ACL tears that are getting reconstructed is around 100%.
Yeah. Yeah. Well, with us, I guess it's always the age of the patient and the future sporting goals. Yeah, I guess are the main deciding factors. And if they're young and they've got high sporting goals, I guess the default is that you need the surgery to live your life the way you want to live it. But we're not, as you say, 100% convinced that's actually true in all cases, anyway. And well, this has been terrific, Ian. Just to you've been very kind with your time. We're moving up towards the hour, so we'll let you get on with your day. But I thought just to wrap it up, if you might be able to help our listeners who may be thinking of going in for a consultation with an orthopaedic surgeon, if you give them some tips on what sort of questions you think they should ask. I'm sure you have patients come into your offices with their lists of questions. What sort of questions do you think are the best?
So there's a couple of bits of advice I give people, because I get asked all the time. People come to me and they say, "Oh, just yesterday, I've just come back from leave, and I had my first clinic back from leave yesterday." I saw patients who say, it's been recommended that I have this operation, but I don't want to have it. And, what do you think? Do I need it? And, which is a very common sort of consultation for me because of my reputation. And my advice for patients is, first of all, consider a second opinion, because patients often don't want to get a second opinion, not just because of the hassle factor, because they don't want to offend the surgeon. And trust me, surgeons pretty hard to offend, and surgeons don't mind. They really don't mind if you get a second opinion. I don't know any surgeon that really minds when a patient gets a second opinion, because if the second opinion agrees with them, great, and if it doesn't, then the patient gets the choice of deciding who to go with. It's not a big deal at all. So definitely get a second or even a third opinion. But when you're with the surgeon, the questions you need to ask is, what's the evidence that having this operation that you're recommending is going to be better for me than if I don't have the operation? And that sounds like a really dumb question. Like, that really sounds like, why would you ask that? Clearly the answer to that, we know the answer to that, otherwise the surgeon wouldn't recommend it. But you ask them that question, and that sometimes really puts them on the spot. Just say, what is the evidence? You've recommended that I have a, rotator cuff repair, or knee, meniscus taken out, or something like that. Just ask them, what is the evidence that having this operation is going to be better for me than if I don't have it? And sometimes they might not have that evidence, and sometimes they'll be honest with you and just say, well, it's not that clear. We don't know whether you're going to be better off, but it's just an option for you. And then it becomes a lot clearer, about how sort of urgent or necessary this procedure is.
Yeah, well, that's a great one. I hope people prepare those questions and get as much information as they can before making that decision whether to go for surgery or not. All right. Well, thanks very much for your time, Ian. It's been terrific. I'm sure our listeners will find a lot of great information there. And if you want to get in touch with Professor Harris, we'll put his contact details. Your clinic's in Liverpool. Private patient.
Liverpool in Sydney. Yeah, I closed down my private rooms a few years ago, and I only consult in a clinic at Liverpool now. But that's where I see private and public patients all together now.
Yep, terrific. All right. Well, thanks very much for your time, Ian, and it's been a pleasure to have you on. And if readers want to have a look at the books, don't forget The Surgery, The Ultimate Placebo, and the latest one, Hippocrasy, that has received rave reviews. I noticed you got a great review from Kate McClymont from the Sydney Morning Herald, as well as Dr. Norman Swan and other high-profile people out there. So I'd highly recommend having a read of those books. And they're not written in a scientific way. They're written in a way that I think the general public can understand. So if this is something that interests you, I'd highly recommend checking out those books as well. Thanks very much for your time, Ian.
The Knee Gurus, brought to you by Asia Physio, providing world-class physiotherapy care across Asia. Visit our clinics in Tokyo, Singapore, Niseko, Hakuba, Nozawa and Myoko, Kogan.